Next speaker is Pierre-Yves Bochud from Lausanne, Switzerland, and the title of his talk is Individualized Genetic-Based Approach to Invasive Aspergillosis Prophylaxis.
I will start with a general overview of the innate immune system. As it has been shown by the previous speaker, when the pathogens go through natural host defense barriers, these pathogens interact with different molecules from the immune system. Some of these molecules are soluble factors, such as the complement. Some of these factors are cells, like macrophage, dendritic cells, phagocytic cells. And these cells can detect molecular patterns from the pathogens, and upon this interaction, they will produce inflammatory molecules, cytokines, that will allow adaptive immune responses. And this adaptive immune response with antibodies and effector cells will help to eliminate the pathogen. The idea of host genetics is that when there is a genetic variation, if some of the molecules involved in this immune response could be in the detectors of these molecular patterns from pathogens or cytokines or different other molecules involved in this response, then the individual will lose his ability to eliminate the pathogen, or who have a lower ability to eliminate the pathogen. So based on this, we can consider possibly that polymorphisms in important genes for immune responses may be relevant in the individual ability to fight infections. So with regards to invasive aspergillosis, we know it is still an important issue with important mortality and morbidity among 15%, although I think it's improving with better treatment strategy that we have now than it was like 20 years ago. Mould-active azoles have been approved for prophylaxis in these patients, but their use is somehow controversial. It's used in many centers, but other centers prefer not to use them because there is a relative high number of patients needed to be treated to avoid a single infection, because interactions, toxicities, and cost of these drugs, and also because the emergence of azole-resistant mold with high mortality, more difficult to treat situations. So it would be very useful to have a tool that could predict which patient is really likely to develop this infection and which patient is not likely to develop this infection, and possibly a genetic testing could be part of this. In an initial study performed quite some years ago now, we had shown that polymorphism in a gene that was mentioned before, toll-like receptor 4, which is involved in the detection of mannan, a component of fungal pathogen, or fungal membranes, was associated with increased susceptibility to invasive aspergillosis. And this initial study was performed among patients with allogenic transplant. The specificity of the study was that the polymorphism in toll-4 was found in the donor, because the immune system relies after transplant mainly on donor cells. It was a functional polymorphism previously shown to influence the function of TLR4. The SNP has a relatively rare frequency, about 7% of minor allele frequency, and we were able to show this association in both discovery and replication cohort. And based on this finding came the idea that possibly we could predict which patient would be likely to develop invasive aspergillosis before we start transplant by using a combination of risk factors. And in this case, we used the combination of CMV seropositivity and the presence of the TLR4 polymorphism to stratify the patients into 3 groups. So we have patients with low risk, which is CMV seronegative and does not have the polymorphism, and a group with very high risk, which combines both risk factors, especially the polymorphism, and a group intermediate, which is with intermediate risk, which has only the CMV positive serology. After these studies, different investigators look at other receptors involved in immunity against fungi to determine whether other factors could be also associated with susceptibility to the disease. And it's difficult to mention all of them, but among them was a polymorphism in dectin-1, which was also associated with the risk of Aspergillosis in recipients from hematopoietic stem cells. The SNP was present in either donor or the donor and the recipient. It is a stop codon, so obviously the dectin-1 function is altered by the polymorphism. It was relatively rare also, and dectin-1 deficiency was obviously associated with invasive Aspergillosis, but this was also confirmed by functional assays. Interestingly, the molecule that is important for signaling of dectin-1, CAR9, can also have polymorphisms, which can be associated with other types of fungal infections, such as chronic mucocutaneous candidiasis and other forms of Aspergillus infection. So this really shows the importance of this pathway in immunity against these pathogens. I would also cite more recent studies because the field is evolving, and very recently has been published an interesting study on the whole of molecules involved in activation of phagocytic cells in 2 genes, RNT2 and 6-3CR1, chemokine receptors. They are polymorphisms that can also be associated with invasive Aspergillosis. So we have an increasing number of studies showing such association with different types of genes, different types of polymorphism. Among them, a lot of studies also looked at polymorphism in cytokines or cytokine receptors. And we come to, from initial studies showing some association and possibility to stratify the patient, we come with a picture with a lot of studies, a lot of associations that are shown in red. And I can show that in the form of a table with most recent study added to the table. And the question comes, okay, we have associations with many genes, many polymorphisms, but what are we going to do in the clinic? Is it really relevant? Can we really use those associations to predict the outcome of our patients? And which of these polymorphisms shall we choose for the clinical experiment? So I would, to address this, I think we need to consider the limitation of this association study and to give a ranking of quality among studies to try to find out which studies are really relevant and which factors make a study really relevant for use in clinical practice. And among the problems we have with some studies, the fact that the definitions are not always homogeneous, the use of controls are not always optimal in some studies. Sometimes the controls are not have the same risk as the cases. Some studies do not account for covariables that are important for establishing the risk. Some of the polymorphisms are very rare, and it's difficult to replicate this association. And without replication, it's difficult to really use such a factor for a clinical trial, for example. There are changes in the epidemiology in different centers. There's use of prophylaxis, which may totally alter the type, the risk, and the influence of these polymorphisms. And one of the most important limitations is that possibly some investigators do look at a lot of polymorphism, and they can select for publication or functional studies the ones that are associated without making correction for multiple testing. And there is also a publication bias. So overall, all these factors make it somehow difficult at some level to use one of these polymorphisms or a combination of them in clinical practice. So now, to my knowledge, it's not been possible to use this polymorphism really in the clinical practice. Now we come to factors that would be necessary to do so. We would need a polymorphism with very robust association and replication, I believe, in different studies from different centers. We would need polymorphism with reasonable frequency, because it's much easier to address in a clinical practice when you test the patient and you have a relatively high number of patients with and without the polymorphism to make a difference. And we would need a polymorphism with a reasonable impact on the outcome. If you have an odd ratio of 1.1 or 1.2, it's difficult to really make a clinical trial with such a factor. And the question is whether in the list in which I presented before, do we have such polymorphisms that address this? And I believe in the last year we got one of them that is particularly relevant. This one is PTX3. It is a fluid phase pattern recognition receptor identified about 20 years ago already by Italian groups. PTX3 is important with the immune response to Aspergillus because it binds to conidia. It's able to favor opsonization and phagocytosis and to influence the killing of the pathogen. And some years ago, in a very nice study published in the New England Journal of Medicine, the group by Cunha and Luigi Romani have shown that patients with polymorphisms in PTX3 have a deficiency in the PTX3 expression, and this deficiency is associated with an increased risk to develop invasive aspergillosis. This was shown in allogenic transplant patients, and the risk allele was, as it was the case in previous studies, in the donor. Recently, we were able to show that this polymorphism was also associated with invasive aspergillosis in a different population, which are the patients with acute leukemia. So before these patients go to allogenic transplant, they undergo induction chemotherapy with prolonged neutropenia, and during this phase they can develop also invasive aspergillosis, and we're able to show that the carriers of the polymorphism at risk also have an increased risk to develop the disease. So altogether, PTX3 becomes a relatively robust a gene with a relatively robust association with invasive aspergillosis compared to many other of these polymorphisms in other genes, because it is clearly associated with invasive aspergillosis in allogenic stem cell transplant recipients, and this was also confirmed by a group from Seattle in the United States in 2017. We were able to show the association, as I just mentioned, in patients with acute leukemia, but also we showed that this association was also present in solid organ transplant recipients, so patients develop less frequently invasive aspergillosis, but still they are at risk. So we can see this polymorphism to be important in three totally different patient populations who can develop aspergillosis. I think it makes this polymorphism really one of the best candidates for the application in the clinical practice. So, in conclusion, there is increasing evidence that host genetic factors influence susceptibility to EA in immunocompromised patients, and PTX3 is emerging as a promising factor because it is replicated in different populations because its frequency, I didn't mention that, is relatively high. About 1/3 of patients are homozygous for this polymorphism and have this increased risk, and it opens the way to clinical trials. I would like to show you now the design of a clinical trial that we started about 1 year ago in Switzerland, but also involving centers in Belgium and France. And so we decided in this trial to screen patients with acute leukemia to have a certain inclusion and exclusion factors based on the fact they receive an intensive chemotherapy with prolonged neutropenia. An eligible patient will be genotyped before chemotherapy is started, and we will stratify the patient in the high-risk group who have the risk polymorphism, about 30% of patients. Those patients are randomized in a 1-to-1 group to receive posaconazole or not posaconazole, which means, in general, fluconazole prophylaxis. And the low-risk group, 2/3 of the patients, will be randomized in a 1-to-3 ratio to receive posa or fluconazole prophylaxis. And the idea is to show in this study that in the end, if we provide the posaconazole prophylaxis only to high-risk patients, we have a much lower number of needed to treat patients to avoid a single infection. So the idea is to focus the treatment on patients who really benefit from it and avoid all the side effects, toxicities, costs, and so on to the patients who are at lower risk. So we will, the trial is started with, we have 50 patients involved. We will try to involve 300 patients in the next 2 years to see if we can verify this hypothesis. I would like to thank the collaborators who participate to this study, in particular the collaborators for the Swiss transplant cohort study and the Funginus group, Fungal Infection Network in Switzerland. And thank you for your attention.
Thank you. This paper is open for any questions. Maybe I'll go ahead and get started. So in those patients that actually have the polymorphism in PTX3, did they have any history of any prior infections or increased susceptibility infections? You mentioned that when they developed acute leukemia, they were at higher risk for developing infections, but looking back in their history, did you see anything of maybe more prone to being to have other types of infections?
No, a few patients may have developed Aspergillosis just when they come to hospital, but those were excluded from the study. We only looked at patients who didn't have Aspergillosis or didn't have antifungal treatment for the study.
I had a couple of questions. Approximately what fraction of susceptibility to invasive aspergillosis do PTX3 mutations account for?
In the different studies in allogenic patient and leukemia, the odd ratio is about 3 to 4.
Okay, so that's way better than, again, previous studies, I think. So, and then similar to previous questions, has anybody looked at the SNPs in PTX3 and allergic disease susceptibility?
Sorry?
Allergic disease susceptibility, not non-invasive disease.
I am not aware of for allergic disease, but some studies have shown susceptibility to other infections, including some viral infections. I think one study about CMV.
David?
So I want to imagine, Pierre, that we have fantastic markers, all right? That everybody now knows that this marker says this is patient quite likely to get Aspergillosis, and this patient's not likely. And then transfer that to the high-risk populations, AML, solid organ transplants. So let's imagine that the low-risk patients have got like a 1 or 2% risk, because it won't be a 0 risk, I think, it will be low. And at the moment, we don't recommend prophylaxis for patients with low risk. And the second half is if the risk is 30% or 40%. That's obviously very high. How do you think our hematology colleagues or our transplant colleagues will react to that information? How will they respond? Will they just give prophylaxis anyway to everybody? Will they say, don't transplant this patient? Will they give double prophylaxis? Will they add immunotherapy on top? Will they give moderated immunosuppression? How do you think, if we can get to that level of discrimination, which I think may be possible, how do you think it will work in clinical practice?
Well, I think one first point maybe I should mention is all the participants to the trial are groups who do not provide posaconazole as a routine prophylaxis. So we selected centers who do not have this first level of prophylaxis, and it's easier to add prophylaxis than to remove. That's first point. Now, if we had very good markers, I think, it depends also the combination of the strategy. You can give prophylaxis, or you can follow your patient with regular galactone Manan testing and scanner, and that's actually what we do. And with the efficacy of treatment we have now, the rate of mortality is really going down. So I think it's reasonable to imagine really to give prophylaxis to high-risk patients and to keep surveillance and for the other patients, because even with that, the risk of death now is controlled to a very good level. So I think practically it could be possible to move to personalized strategies in these patients.
So the PTX data are really beautiful, and I suppose there'll be a few other polymorphisms that look this sound as predictors, but there were so many others. I wonder, and there must be a lot of overlap between what they're doing. I wonder if this doesn't, it's kind of painful to suggest this, but maybe it has to be put together in some sort of mouse model where you do quantitative genetics on all the different possible combinations of these things. Is somebody doing that, or?
Not to my knowledge. I think it becomes very complex because there are so many markers. I think there is a laboratory approach on one side and the epidemiological one. And for the epidemiological one, it's difficult with the size of the cohorts we have now to make so many combinations. I'm pretty sure there are other markers, and in the future we will probably combine them and be more accurate in the risk prediction. But the limitation is really the size of the cohorts. For the animal model, it's not necessarily my field, but I can imagine we can select 2 or 3 of the most relevant ones and try to see if the combination really further increases the risk.
Thank you.
Yeah, just to follow up on that, I'm not aware of any animal models that have done all of the mutations, but it does ask, I think the question really does pose as to, are we ready as a field to look at polygenic scores and now look at patients, since you have that beautiful slide where you have nearly 10 or 15 different, can we now, for many other diseases, and I'll just pick heart disease as the one, we don't focus on just whether someone has diabetes or not, but we look at diabetes, heart, their hypertension, whether they smoke or not, and their cholesterol levels as kind of the major ones. So are we at a point where we've now identified maybe some of the major ones, and a polygenic score will get closer to the question, whether we should weight all of these and maybe approach the utopia that David was talking about?
Maybe if we combine the largest cohorts, we may slowly become to that. Another question, which is more philosophic, is whether susceptibility to infection like Aspergillosis, which didn't exist possibly during evolution, really these patients develop Aspergillosis because we do chemotherapy. So possibly we have polymorphisms which have a stronger role than those involved in diabetes or metabolic disease because it's an artificial, or it's linked with medical evolution. But I have no definitive response to this.
Excellent. Great. Thank you, Pierre.
Thank you.